Good morning. I'm Rubén Sánchez. I'm anesthesia manager, cardiovascular team in Hospital Clínico San Carlos from Madrid, Spain. And we are going to talk about Quantra, blood, and recovery. I would like to have that recovery for our patients. It's a myth of no doubt, we must have blood. Charles Dickens said in her autobiography novel in 1849. And that's true. When we have cardiovascular major surgery, sometimes the surgeon must take out the blood of the body. And this is a problem. Like my child knows, when the blood goes out of the body, it scrubs and it makes a clot. It's not possible because we need that blood. In major cardiovascular surgery, there are many changes during the blood. Hemodilution, thrombocytopenia, change of laminar flow, platelet adhesion to synthetic surfaces, changes in factors. For example, only 1 hour of cardiopulmonary bypass lay down fibrinogen, more or less 40%. Other factors, near 30–40%. And platelets, 40%. NATA was found in 1998, but from early 80s, we know it's very important for us the treatment of anemia. For example, red blood cells in anemia patients usually don't go in the middle in the vessel. They go outside the vessel, inside the vessel, but outside. So the factors can go to make her job. In massive bleeding, we have main actors. Many times they say we have secondary and main actors. All are main actors. We might be allowed with acidosis, temperature, endothelium, glycemia, platelets, factors, of course, plasma proteins, and calcium. Everybody of you know the classic coagulation cascade, but it's explained many things for us, but only trying to explain academic things, not the real life. Because hemostasis is not coagulation. It's only a part of what we want to do, a tissue repair process. Our body needs to live, needs the blood to live, and when the blood goes out of the body, they want to tissue repair a tissue repair process. So what can we do? We need something that use whole blood to analyze. But are the different coagulation factors equally significantly? No, they are not the same. In Spain, we have importational tradition in hemophilia, our kings. We don't need 100% activity all of the factors. Probably only with 30% we are okay. And what about intrinsic pathway? Intrinsic pathway is not the same paper for coagulation. It's more than secondary paper in hemostasia beginning. It's more activated inflammatory process. Try to repair the tissue. Classic coagulation tests are not enough for managing surgical bleeding. They are so slow. When you are faced to surgical bleeding in aortic repair, for example, you go out, you take your computer, you make the paper, you take the sample, you send to the laboratory test, and after an hour, you have the result. We cannot do that. Thromboelastography date from 1948. We are in 2024. That time, there was a very slow method of measure, but they allow us to understand a new way to treat the coagulopathy. We can divide the coagulation in two phases. Thrombin generation, in which we can help us with factors, with plasma, with factor 7, wherever, and the clot formation and lysis of the clot. We can influence the body with platelets, fibrinogen, or tranexamic acid, for example. Let's talk about a case and try to understand what are we going to do in a very bleeding case. It's a thoracoabdominal substitution on pump. We are going to change the aorta from subclavian artery, left subclavian artery, to iliac bifurcation. Okay? What do we need?
No.
Probably we need a good anesthesia team, of course. We need good coordination and communication with the operating room team, with nurses, with therators, everything. A fluid dialogue with blood bank. We must be all the time talking with blood bank. A good autologous recovery, better is same. And a fast and reliable POC analyzer, point of care analyzer. What do you expect from an hemostatic POC? Trust of the surgical team, of course. Your surgeon must believe what you are doing. Correlation with known tests. Classic test and known test. Easy and safe. Reproducible interpretation. You cannot take one point of care test where somebody say you need platelets or somebody say you need factors. Fast and accurate on whole blood test and easy interpretation. We must include all principal actors in hemostasia, sensitive to heparin, correlation with clinical hemorrhage, normothermia, and no contact with blood. We have been using in our institution from 2015 point-of-care coagulation test. And since we use that, we have so many things. In major vascular surgery, we have almost 60% less red blood cells, almost 75% less platelets, and almost no plasma. And in cardiac surgery, something similar. 28% less blood cells, 11% less platelets, and almost no plasma. We have spent a lot of fibrinogen, more fibrinogen than later. During last year in our institution, we have been working with all viscoelastic tests, TEG, ROTEM, Quantra, and ClotPro. We take 3 samples from the patients. 1 sample on the baseline, another sample in the warm-up period, in normothermia, before the statin cardiopulmonary pump, and then after protamine or another rheological things we need. Let's return to our patient. We take laboratory tests ROTEM, Quantra, and Activate Blood Bank, of course. In our Cell Saver, we have recovered more than 6,000 milliliters of blood. We have this Quantra. I will explain now what we see in that Quantra, and that's the surgery too. Here are the classic tests. We are in the warming on pump. What do you need to make Quantra? It's so easy, because we need only 2.7 milliliters of filtrated blood, get the tube, put inside the machine, and let's do it. The machine uses ultrasound to analyze the clot. When the ultrasound passes the cube and the blood, they estimate the displacement by the clot stiffness. When the clot is more stiffness, increase the frequency of oscillation. We measure the clot time and the clot stiffness. We have a 4-channel cut rate in which we can measure clot time, is the time to make the clot in intrinsic pathway with heparin or without heparin, and we have the calculation to put the protamine. Clot stiffness, extrinsic pathway, clot stiffness due to fibrinogen, and clot stiffness due to platelets. And let's see in our studies what's the matter with the correlation with Quantra, ROTEM, and classic tests. Let's start for the best one. Extrinsic pathway. Extrinsic pathway have very good correlation with Quantra and A10 XTEM from ROTEM. Fibrinogen, not only Klaus test, A10, 510 from Quantra, and FCS from Quantra is very good correlation. Classic test and point of care test, very good correlation. Here is the problem and the things we have seen many times during our years using point of care. Most of the time, ROTEM said there is no perfect INTEM, no perfect EPTEM. But we don't see clinical hemorrhage. So most of the time, the team, cardiovascular anesthesia team, don't put anything to the patient if the clinical hemorrhage was not significantly. And here we can see with APTT, no correlation, and Quantra and INTEM, no good correlation, a little bit correlation, but not very good correlation, 0.65 or 0.56. Always with INTEM or with EPTEM, in warm-up period or post-protamine period. But we have seen very good correlation with Quantra and clinical hemorrhage. And what about Quantra and platelets? We try, in classical tests, we only see the number of platelets. We don't see the function of platelets. In Quantra, we try to know the function of platelets. So correlation is the middle one. You can see the graphs. In this situation, we need point of care with rapid solution. We need fast solutions. And Quantra is faster than other tests. Quantra is faster near 4 minutes than ROTEM But we have, see, Rotem A5. We don't use Rotem A10 that they use in other studies. We use Rotem A5 because most of you can say perfect, but when you look to Rotem, you start to make decision without getting A10. So we make the measure from final Quantra results to Rotem A5. It's the same difference in basal 1 and warm-up. In our study, we use 50 patients, and median Euroscore was 30.02. So we use in very difficult patients and very difficult situation and surgeries. Redo, 2 valves, 2 procedures, or 3. So let's treat our patient. Now we have understand what Quantra do. We know what's the matter with our patient. We know how to read Quantra. So let's put 6,000 autologous recuperated blood, 6 red blood cell concentrates, 9 grams of calcium, bicarbonate, fibrinogen, octaples, and 3 platelets pools, because we don't have ISAME, probably. And these are these results from Quantra. Let's see. CT is a little bit longer. CT heparin is the same, little bit longer. So CTR is okay. We don't need more protamine. Heparin and protamine is okay. Cloth stiffness is okay. Stringent pathway is okay. Platelet contribution to cloth stiffness is okay. Fibrinogen contribution to cloth stiffness is quite good. So in this case, we put 2 plasma bags. So what do you expect from Quantra? What do you need? We have answered before, what do you need for our point of care? Probably we can answer now. Trust of the surgical team. Perfect. Our surgical team is all the time asking, have you used the machine? How is the machine? We don't do the machine in that surgery, but they answer all the time for the machine. Correlation with no test. It's good correlation with the test. Easy and safe. It's very easy. We are 12 anesthesiologists in cardiovascular team in our hospital, and all of us have the same interpretation between. It's not so easy with Rotem nor with TEG. It's fast and accurate. It's faster than other point-of-care tests. The order in fast is Quantra, the fastest, Rotem, the second one, almost 4 minutes, TEG, the third one, and Clot Pro, the fourth one, in faster way. Whole blood test, of course, easy interpretation. Include all principal actors? No, that's not possible. We need to manage calcium, we need to manage glycemia, we need to manage acidosis, temperature. Heparin sensitive, of course, correlation with clinical hemorrhoids, better correlation, not statistically significantly, but it's only 50 patients. But good correlation, normothermia, and no contact with blood. And what are our challenge? What we are working on it? Antiplatelet therapy is quite difficult to analyze in only point of care. We need another machine like Verify, like another ones. Anticoagulants, direct oral anticoagulants, low molecular weight heparin, and antidote evaluation. We need to work it. Thank you.